We're now live, Chairman.
Thank you, James. Okay, I would like to begin by welcoming those members of the public and press who may be watching this live stream via the Council's website. Committee members, you are aware by now the need to keep your video camera switched on for the duration of the meeting, unless there are the inevitable technical issues, and to keep your microphone muted, except when I invite you to speak. Please click the raise blue hand function if you wish to ask a question or make any comment. There's always a risk, as we well know, that we may run into those technical problems, and I would ask for patience if we do. Should this occur, I will declare adjournment until the fault is addressed. If not possible, the meeting may be abandoned until such time it could be reconvened. I'd like to remind all members and officers and public speakers that all virtual meetings will be recorded, and these recordings will be published on the Council's website. Members, I will begin by calling the names of all members of this committee to establish your presence. Please unmute your microphone and confirm your presence. Councillor Connor.
Present.
Councillor Dupre.
Present.
Councillor Hay.
Present.
Councillor Harford.
Present.
Councillor Jones.
Present.
Councillor Nethsinger.
Present.
Councillor Reynolds.
Present.
Councillor Smith.
Present.
Councillor Van der Ven.
Present.
Councillor Ambrose Smith.
Present.
Councillor Clark.
Present.
Thank you. Councillor Harvey.
Present.
Councillor Massey.
Present.
And Councillor Taverner. Jill, are you here? No? Okay, we'll move on. And there's myself, Councillor Hudson. Can I ask, please, Rob, to update us on any apologies?
No apologies I have received.
Okay, so we're just missing Councillor Taverner. Okay, thank you. Does any member wish to declare any disclosure of peculiar interest or non-statutory disclosable interest, please? If so, just use the raised hand function.
I can't hear anything.
I have no raised hands function, so there are no interests, so thank you. Excuse me. Item 2, we're asked to approve the minutes of the meeting held on the 25th of June as a correct record. These have been emailed to all members of the committee. Could I ask, please, if you agree that it's a correct minutes of the meeting? If you have anything to say, please raise your hand. Councillor Clark. You have a hand raised.
Yes, sorry. When I'm reading through this, I see that I'm not on the co-opted district councillor appointments, and I was
Yeah, apologies, Councillor Clark. I'll make an amendment to the minutes for that. Sorry about that.
Thank you.
Thank you, Sam. Could you take your hand down, Sam, please? Thank you. So is everybody agreed with that amendment by Rob, that the minutes are correct and I can sign them off when I'm available to do so? Thank you. So we'll go on now to item 3, which are petitions and public questions, and we have received no such questions or petitions, so we will move on straight away to the next item, which I believe is the COVID-19 report. As we all know, our officers have been asked to bring a report on the COVID-19 response to date for those services in which each policy and service committee is responsible. A similar report will be brought to all meetings until further notice, and given the rapidly changing situation and the need to provide this committee in particular and the public with the most up-to-date information possible, I have accepted this as a late report on the following grounds. The reason for its lateness is to allow the report to contain the most up-to-date information possible, and the reason for the urgency is to enable this committee to be briefed on the current situation in relation to Council's response to COVID-19 and for those services which this committee is responsible. Can I now ask our excellent Director of Public Health, Liz, to introduce a report, please?
Thank you, Peter. Looking at the local public health context, which is the second section of the report, we have had a major change since the last meeting of the Health Committee in terms of reporting. So nationally, we're used to seeing COVID-19 cases reported on daily on a National Public Health England dashboard. And the national numbers of cases have included for some time cases that were identified through local laboratories and cases that were reported through national laboratories. Local authority cases have only been reporting back on cases from local laboratories. So the most recent change has been quite significant in that local authorities since July the 2nd now have the numbers of cases through both local and national reported against them. Just to go into this in a little bit more depth, the cases that we have been reporting to date are in a sense what are seen as the most reliable results. So they are tests that have been carried out mainly in hospitals or in care homes, and those get sent to our local Public Health England or hospital laboratories. So it's the people who become most ill and who do end up in hospital or who are symptomatic at a care home. Those are the cases that we've been recording. The national, the cases where the test is processed in a national laboratory are those which people book themselves over the internet, and then they go to a drive-through centre, which initially was Stansted, then we had Peterborough Showground, now we've got Milton. There's also some cases through the mobile units that go around to different venues, so those numbers are smaller. And also increasingly, it's tests that people book over the internet and get sent a swab to take at home. And one other part of the national testing is whole care home testing, where a care home can test all its staff and residents in one event through swabs sent to them from national labs. So often what we call the Pillar 2 national testing is for people who are not ill enough to go to hospital. So it picks up much more of what's going on in the community with cases and testing. What we've found in Cambridgeshire is that all the tests done under those national labs have been added to our statistics. That means that we have sort of had a jump to 2,193 cases recorded, about 2,200 cases. And we have a new rate of COVID-19 infection over time of about 340 per 100,000. We can also see the spread of cases between the different districts. Huntingdonshire is the highest and actually overall is above the national average, whereas South Cambridgeshire, East Cambridgeshire, Cambridge are lower. So we do have a lot more information and it is quite a big change. So I wanted to reassure you that's not because we've had a jump in cases, it's just because the recording has changed. And actually Cambridgeshire's position, in a sense, hasn't changed that much. We've not had a sudden jump to the bottom or top of the league table. We're still sort of below average overall. But it does look very different. So that's the change in testing, and it's not in the paper because it's even more recent than yesterday's publication. But just looking at the sorts of numbers of cases that we're getting through both types of tests, if we look at the reporting period, sort of around a very recent week, we're looking in the order most recently of sort of 14 to 18 cases. We're not getting a lot of cases, even counting both the local and national laboratory sources. And our overall trends in cases are downwards. Our trends in our hospitals are generally downwards, and our trends in deaths are downwards. So that is a reasonably positive position at that point. Although clearly with the release of social distancing measures, we are watching very, very carefully because of the changes in the national lockdown rules. We are watching very, very carefully as to what happens going forward over the next week or two. So that's our public health information. The system response is still very much going on as a council. We're working closely with partners across Cambridgeshire and Peterborough, really on both COVID response and recovery. And our strategic coordinating group is continuing to meet and keep a focus on what is going on. And there's also a strong focus on the reopening and doing that safely. In terms of the public health services response, I'd particularly like to emphasise the local outbreak control plan, which was published on the 30th of June. The paper describes the 7 work streams which are covered, and I've talked with you about that before, so I won't go over all those work streams again. But fundamentally, the plan is about making sure we have a good local system to prevent, identify and manage outbreaks, with the testing working, the communications working, managing of outbreaks in settings working, and all in a timely and effective integrated way. So that our local outbreak control plan was discussed at a special meeting of the Health and Wellbeing Board's Whole Systems Subcommittee on the 29th of June, which had the full membership of both boards, and I know some of you were there. There was a very good contribution from the board members, emphasising the contribution that community groups and volunteers working in district hubs and very local areas had made to date in the COVID-19 response, and the importance of that continuing in the local outbreak control plan days. So that feedback was incorporated into the final version of the plan. And indeed, I have spoken to the chief execs of 4 out of the 5 district and city councils in the past week, just to have that conversation and really emphasize the need to keep those local community resources going. And the chief execs are extremely supportive of that. So that is the local outbreak control plan, and we are now very, very focused on implementing the plan and ensuring that the right measures are in place. So we have a surveillance group which looks at all the data, which meets at 9 o'clock every morning, Monday to Friday. And we have an outbreak management team, which meets at 10:30 every morning, which receives data from a summary of data from the surveillance group, but also information from Public Health England, Regional Public Health England, on any cases in complex settings like nursing homes, schools, specific workplaces, and any local outbreaks. And that outbreak management team takes the overview of everything that's going on, logs it all, keeps an incident and outbreak log, documents, and has a single email point of contact. So it's running as a typical incident management function. And this is proving effective. Underneath that sit a number of multi-agency cells, which would specifically deal with outbreaks in a care home, the care home cell, in a school, the schools and early years cell, workplace cell, and so on. So we have all those operational arrangements in place. And the overall activity is overseen by a multi-agency health protection board, which actually met this morning, an officer board, and it meets weekly. And the detailed action plan to support our headline local outbreak control plan will be overseen by a programme delivery group, which sits under the Health Protection Board. And our first public meeting of the member-led local outbreak engagement board will take place tomorrow. So a lot of activity going on there. one outbreak that I'd like to flag, which received media attention at the time, was the outbreak at Prince's Factory, Wisbech, and just to report back that that has now stabilised. It's been fully managed in a very collaborative way, and we are seeing the cases have dropped off, and it has now stabilised. So that's something positive to bring back to the committee. I think the ongoing work of the public health team you're familiar with. It is detailed again in the paper, but I'm happy to finish there and take any questions. On mute. Councillor Hudson, I think you're still on mute.
Thank you. Thanks very much, Liz. Please use the raised hand if you wish to make a comment, members, please. And I'll start with Councillor Harford.
Thank you, Chairman, and thank you very much for that report, Liz. That's really useful to hear from you. There's absolutely no doubt that you and your team are doing a lot of work. I think I heard you say now that we're getting about 14 to 18 cases each week. Do we have a breakdown across the districts for where those cases are occurring? Huntingdon remains a huge concern for me, I may have missed it, but so far I haven't seen any rationale as to why Huntingdon might have been so badly affected. Is there any further work being done on establishing why there are the problems in Huntingdon, and are the current cases showing a similar pattern, with Huntingdon having the lion's share of them? Thank you.
Okay, thank you, Councillor Harford. I think that's a very good question, and the cases are published at lower tier local authority level now on the national dashboard. So you can see the increase in cases in each district each day if you follow the dashboard. And obviously we follow that in the surveillance group. So going back historically, there has been quite a bit of analysis, although including the Pillar 2 cases, and I think it's fair to say that in the evidence we have in Huntingdonshire, which absolutely, like the other districts, has peaked and has now come down, so it's very, very much down on where it was, is quite a strong link, certainly for the Pillar 1 cases, with the health and social care settings. So we were seeing a lot of positive results from those settings. And I can reassure you that there has been a big decrease in Huntingdonshire, but we are continuing to monitor that very closely. Probably overall, we are seeing more cases, I would say, in Huntingdonshire and Fenland than in the southern part of the county at the moment. That's different from the start of this pandemic, when we were seeing more cases in Cambridge and East Cambridgeshire right at the beginning. So it does, even within our area, it does move around geographically. And Fenland, I think, particularly with the outbreak at Prince's, that identified a number of cases. And also we're becoming increasingly aware that there are outbreaks at food processing factories. Those do seem to be higher risk settings. So when we think about our businesses and industries around Cambridgeshire, we might expect to be, looking out specifically for those issues. But I would reassure you that we do monitor this very carefully. Even if there's quite a small increase in cases, we will look at that and analyse what the cause is, and do quite a bit of work on it. But overall, we are seeing, sorry, I'm a bit hoarse, but we're seeing Cambridgeshire in a much improved position, and Huntingdonshire has decreased as well. So I can reassure you on that, but we're keeping a very close eye on it.
Thank you very much for that. Chairman, may I ask another question?
If it's very quick, please.
We've seen with the Leicester outbreak that there were some underlying problems that, not having been addressed for their own merit in the past, have now caused this, or have certainly contributed greatly to this spike that they're seeing. Are we aware that in Huntingdon there are any particular concerns about other underlying causes that might be contributing?
I think if we're talking about risk factors in the population, we we are very aware that there is a link to deprivation. There's a link to having ethnic diversity and potentially multi-generational households, but also higher risk for some Black and ethnic minority groups. There's a risk to housing in which people are crowded together. And there are a risk to occupations where people are very much in contact with the public and very front line. The biggest risk is age, and there's also a risk with gender. So men are at high risk at the various ages. So there are a number of risks around vulnerabilities, but certainly in terms of population risk factors, whereas we saw quite a general distribution at the start of the big rising cases in the UK. I'm expecting to see that cases are quite likely to concentrate more into our areas of deprivation where we have people living in crowded housing, perhaps quite a wide diversity, and a lot of people doing frontline jobs where it may not, we hope it would always be possible to social distance, but sometimes that may be more difficult. So I think we are looking to particularly be aware of risks in areas of which there are perhaps, you'll be aware of an area in Huntingdon, but there's also areas in Cambridge City and areas in Fenland, and particularly North Fenland, where some of those risk factors would apply. And we do actually have a cell under the Outbreak Management Team for socially excluded and vulnerable populations, which is looking at some of those higher risk populations and how we can work proactively with them on prevention and support. And I think in Leicester, clearly, we had some of those issues coming very much to the fore that have come out in the media around those particular areas and issues. We are now getting postcoded data through on a weekly basis from Public Health England. So we can look at what is happening in particular areas and not just guess, but actually follow where the identified cases are and track that. So that is helpful.
I'm really pleased to hear that, because that was a big concern for me, that despite your competence and commitment, you might not be getting the underlying information that you require. You're the one there at the coalface, you and your team, and I was concerned that maybe some of the information that you rightly need wasn't coming through to you, but I think I'm hearing some reassurance from you that that is no longer the case.
It's greatly improved. We still haven't got everything that we want. The postcoded data at the moment is only coming through on a weekly basis. We want it daily, but we are looking to participate in a pilot where we should get that. And we also would very much like to be able to link directly to what's called the CTAS system, the test and trace system, because at the moment we get the postcodes of the residents, but we can't necessarily link those residents to a specific outbreak or workplace or whatever. And we'd like to be able to actually link our postcoded case data into specific settings or outbreaks. So we'll push for that. But it's a great improvement over, say, 3 weeks ago or a month ago. It's a huge improvement, and we get sort of data flows in, probably 5 different data flows in each day, sets of information in each day.
Thank you.
Thank you. Thank you. Thank you. Thank you, Linda. Could you move on now to Councillor Linda Jones, please?
Thank you. And Councillor Harford asked the first question that I was going to ask. So I think we've heard a kind of positive response to you saying, yes, I am confident that most of the data that I need, we have now got, not all of it, in a way that links to how confident would you be that you could cope with the second spike if one comes along. So I think I've heard a response to that, which is not a full level of confidence, but an increased level of confidence, which is good. And I think we keep asking this question. I know we've asked it several times already. We will ask this question kind of at future meetings, because that is a real concern to us. What I wanted to focus on was the local outbreak control plan, which I have read a couple of times, and it was good to see the changes you made after the previous meeting of the whole system subcommittee. I thought that was excellent. I think the plan is a good one. I think if you're thinking about it from a resident's point of view, and you look at your paper, I think what is striking about it is the sheer level of complexity. And you know, there are gold teams, there are recovery teams, there are restoration teams, there are subgroups, there are public health groups. You know, I think at some stage, and perhaps on your website, it would be very good to have that structure chart I think you showed a little while ago, just to explain to people how things are working. But I found, even though I've sort of followed this story, I found myself finding it quite difficult. Some things have disappeared. When the initial proposals for the local outbreak plans developed, there was an idea that there was going to be the regional local link, but also, for example, that Norfolk was going to be the kind of beacon and the exemplar. That seems now to have gone. There also, I think, in your paper is some confusion between what the Local Resilience Forum Restoration Group is doing and what the Local Resilience Forum Recovery Group is doing, and how the Recovery Group relates to the Restoration Group. What's the relationship? How are they working together, or aren't they? And one of the ways it would be useful to test this is to understand how it worked at the Prince's outbreak, Prince's factory outbreak. What lessons you've learned from that you're taking forward, and what improvements you think you can make. Because in a way, although it's lovely to learn lessons further down the line, it's really important to kind of learn the lessons quickly so the next outbreak can be tackled better. So I'd find it helpful, both the comments on the complexity and the comments on the lessons would be very helpful.
Thank you, Linda. And yes, I always say this, but I would just say in relation to second spike, that is totally dependent on, or very dependent on, how people behave. And I can't come to a committee without saying it is our residents who will make the difference. And with the relaxation in lockdown measures, we absolutely have to keep those key messages about hygiene, social distancing, 2 meters if you can, mitigations if it's 1 meter, go for a test if you have symptoms and self-isolate, follow the instructions if the contact tracers contact you. There's some core things that are going to make all the difference, and whatever we do with our outbreak control team, that is not going to be the answer. It's going to be how the residents behave and the preventive, and to prevent further spread, that is the most important thing. So I just, what you asked about a second spike, and I had to say that. In terms of the complexity, I agree with you. And in a sense, the paper is almost perhaps more complex than it needs to be, because it deals with a number of different things. So we have our Local Resilience Forum and our Strategic Coordination Group structures, which Jan may want to speak about as co-chair. Those are working across a range of issues, including a focus on recovery. So not the outbreak control, which is a narrower part of the picture, but the wider recovery in Cambridgeshire and Peterborough. And very simply, the recovery group, which has a number of subgroups, is looking quite strategically at recovery and how we move forward to a new normal, and how we benefit from some of the lessons that have been learnt during COVID-19. The restoration group is much more operational. It's looking at the nuts and bolts of opening up a city centre or opening up recycling centres. It's a much more operational group that looks at what's happening next and is it covered safely. So they are different. They do have different functions. In terms of the Prince's outbreak, a lot of lessons to learn, and absolutely we are learning those as we go. And quite a lot of those lessons were about communications and understanding when different parts of the system find out we have absolutely learned from those. And one of the lessons that we've taken actually in terms of the relationship between the outbreak control system across Public Health England, Local Authority Public Health, Environmental Health, that bit of it, and the wider Local Resilience Forum, is that we needed to be very clear on that communication channel. So now we are inviting a representative from the multi-agency incident cell, which provides all the information to the LRF. We call it a sit rep. And we now have actually a police representative from that cell dialing into the daily outbreak management team, so that if there's anything that needs to be escalated from the sort of more core, in a sense, public health system to manage the outbreak into the wider strategic coordinating group, LRF, then that communication link is absolutely there on the day, and it can be translated straight through into the sit reps. So that is a bit of learning from the Prince's outbreak, actually, that would be a good thing to do, to make sure the whole system's joined up in terms of information going out quickly. So yeah, we are absolutely, and in fact at Health Protection Board today, which is included in the local outbreak plan, we had a report back on outbreaks that was not a line listing, but was what are the key learning points that we have got so far. So that's very much in there.
Thank you, Liz. Thank you, Linda. Lucy.
Thank you. As with lots of the questions that I had have also been asked by both Lindas, but I'm going to pick up on just a couple of things. The first one is what you were just saying, Liz, about how people's behaviour is going to be critical to keeping the numbers low now that the lockdown is lifted very considerably. I think it's really interesting just how much data has come today compared to the last meeting, that we're getting more information all the time. And I think it's absolutely crucial that that information gets out, not just to you and your team, but also out to the public, because with the numbers quite low, it might be quite easy for people to start thinking that this has gone away, and that's when it will come back. So actually making sure that we are getting information out about where there are outbreaks and where it's relatively safe is very important. And actually my first question was going to be about Huntingdon, and I'm going to go back to Huntingdon. Huntingdonshire is a very large area. I think it would be quite useful for people to know a little bit more precisely within that. So kind of just on the basis of north, south, east, west. My understanding was that outbreak was more in the north. I think it's quite helpful for people to know if I'm right about that, because it helps people to manage their behaviour. I mean, if we're confident that most of that outbreak was in care settings, then most people don't need to change their behaviour. But actually, if there are areas where there is a risk, it's really helpful for people to know that, so that they can think, well, actually, maybe I'll wait till next weekend before going to the pub. That level of information does actually have an impact on people's behaviour, and we want it to. We want people to moderate their behaviour according to the risk, and in order to do that, we have to give them the information in order to be able to moderate their behaviour according to the risk. So the first thing is, am I right that it's kind of the north-ish of Huntingdonshire? I don't want to be any more precise than that. The second thing I think is that it is important to keep getting this information out. I think we do have a meeting in August, and I think it will be helpful for us to do that simply because it helps to get that information out. That I think it's important for us to keep making sure that there are occasions when this gets into the public. And finally, will you be sort of, I know that Christine's been doing a great job in her communication strategy, but that needs to be about giving out the bad news as well as the good news, and making sure that people are aware of where there are concerns. And I'm not sure how brilliant we've been at that in the past, and I hope that we will be doing that over the course of the summer, because I think, as you say, people's behaviour is so critical, and they can't behave sensibly unless we give them the right information. That's all.
Okay, thank you, Councillor Netzinger. I'll be brief because Jan's here,
Yes,
and we need to, and that's
we're running out of time. We need to move on, please.
Yeah. So just briefly, no, I wouldn't be able to say what part of Huntingdonshire the problems have been in, and one of the reasons for that is that when you look at the early data from the national testing sites, they're very influenced by proximity to a drive-through. So that data is the data is a bit ropey in terms of, you know, how easy is it to get to a drive-through testing site, because a lot of people weren't getting tested in the earlier stages. So, and I wouldn't say that there is a specific geographic bit of Huntingdonshire that I would talk about. Secondly, I would say that a big piece of work that is happening at the moment is what we call our rapid response, so that when we see a rise in cases in an area that can be defined through that postcoded data, or if we see that cases are more concentrated there, because it doesn't have to be a rise, it can just be, oh, the risks are higher there. We are working with our district colleagues on a rapid response system, which absolutely involves communicating with the community. And I quite agree with you. We need to be good at getting out the good news, but we also need to be good at getting out, hey, there's a risk here, and please observe the social distancing, behave in these ways. So I'm in agreement with you on that, Councillor Netzinger, and I'll stop there.
Thank you.
Thank you, Liz. Can I ask members, please, to keep their questions fairly short and concise? We're over time and we only have Jan for 40 minutes. Susan.
Thank you. One question, please, relating to communication and local community groups. It was good to see the local outbreak control plan tweaked following those comments, but what I don't see is how that communication and liaison with community groups at very local level is to take place. So there's an awareness that it's important, but it doesn't seem to figure in the system of communications. And all the comments thus far, all the discussion thus far, I think only strengthens the case and the need for maintaining that communication. And I do fear that many of these groups are now in the process of disbanding. I haven't seen any communication recently to local groups about this, about the sort of the new phase.
Again, answering briefly, Susan, and Chair, I would be quite happy to take further questions after Jan has spoken, if that would be helpful, because I'm aware of the timing. But on that one, these are the conversations I've been having with the district council chief execs, because the district councils have been very much engaged with helping to support and maintain those local community groups. And in fact, it is your chief exec that I'm meeting with next, and that has been part of the conversation about it's really important that these groups don't stop at the moment, and we've gone through the 3 functions that we would really like to continue to see happening at community level. So I'll stop there, Susan, and as I say to the chair, I'm quite happy to take a few more questions afterwards if that would be helpful.
Yeah, thanks, Liz. I'm just going to go on for a couple of minutes, please. Kevin.
Chairman, as we push for time, I'm happy to forego that and deal with it another time.
Thank you very much indeed. Jeff.
Yeah, I just wanted to be reassured that this, Liz talked about the 5 data streams and the frequency with you now getting the data. Would the methods we use to analyze that data still work if the number of cases were, say, multiplied by 10? You know, just looking forward.
Yes, we get data from a variety of sources. We have quite a sophisticated actually surveillance cell with heads of business intelligence from the CCG, the council and public health, and then an experienced public health consultant epidemiologist overseeing. So we're doing that, but also at regional level, regional epidemiology unit, there's a lot of analysis of any sort of disparities in the data, any peaks, troughs, exceedances. So, and that's not really dependent on the numbers. That's analysis which will work with any scale, I think.
Thank you, Liz. Thank you, Jeff. Could I ask, please, Lucy, Susan, Kevin and Jeff to take down your raised hand symbols, please, so we can move on. And we're asked to note the contents of the report as a recommendation. Are all members happy to say we have noted the contents of this report? If you don't, please use the raised hand symbol. There's no raised hand, so we've noticed the content of the report. Thank you very much indeed. Next item.
Yes, there are, Chair. There was my raised hand.
Oh, I'm sorry, Laura. I didn't see you. There you are. Yeah, go on.
Okay.
Quickly.
I just wanted to say, Liz very kindly said that she was happy to answer some questions afterwards, and I'm very much aware of the pressure of time on Jan. I think if there is a chance to ask a few more questions, the ones that we are foregoing because of time after Jan has spoken to us, that would be really helpful.
Yes, of course. If time allows, we'll come back to this and Liz, but in the meantime, we'll say we've noted the report. Thanks, Lorna. Okay, let's go on, please, to the COVID-19 CCG update. And I really would like to welcome Jan Thomas from the CCG to our meeting. Jan, we really appreciate during the present ongoing crisis if you accepted the invitation and taking the time out of a really busy schedule to attend the committee today. I know how busy you are. I am going to limit this to 40 minutes. We're a bit over. I do apologise. I hope that's okay still. And so I'll ask the committee to bear in mind to allow Jan to leave us no later than 40 minutes time. So Jan, I'll just start the time. Alexa, set an alarm for 40 minutes, please.
I just looked up at my clock.
Thank you. Sorry.
My Alexa's just gone off.
I love IT. So Jan, we very much welcome a short update on the current position and the CCG response to the Simon Stevens Annex A letter dated 29th of April this year, as this was previously expressed to be of particular interest to our committee here. And as it's a public meeting, you may also wish to provide a background on what the letter was requesting. I will then ask 4 questions that we come up with, chairs and lead members, and I'll give you a chance to respond and then open it to other members. So with that in mind, Jan, very nice to see you. I hope you're keeping well and safe. Thank you and all your team for your great work. And could you like to introduce your report, please?
Yeah, so firstly, it's lovely to see everybody. It felt like quite a while. We've had, I think, quite a few weeks and months. And I guess for those that aren't aware, so I'm Jan Thomas, I'm the Accountable Officer, so Chief Executive of the Cambridgeshire and Peterborough CCG. And I also, as Liz mentioned, because this was a level 4 national emergency for health, I took on the co-chairmanship of the Strategic Coordination Group for Cambridgeshire and Peterborough as well. And under that, I therefore also was the Health Gold Command for the health response for Cambridgeshire and Peterborough. None of which got me a badge or a tabard, by the way, I would like to say, although somebody early on did try and give me a tabard, which I quite firmly rejected. So I really want to start by just saying I think Cambridgeshire and Peterborough overall has done really quite well through this experience that none of us would ever choose to have. And I think that comes down to all of the health and care staff across Cambridgeshire and Peterborough. Anything that we have done as a system, I think it's all down to the work that those frontline staff have done, how they have been flexible, and I'm saying that across the breadth of both care and health, because this was a true team effort. And I think, you know, there are areas on reflection that people would want to change, but there's one thing that passion and that flexibility that those staff have given us is absolutely, I think, blown people like me as leaders of those teams absolutely away. So I just want to keep just saying thank you to those staff, because right now they're pretty tired. And they are still keeping going. And so now more than ever, I think it's important to say thank you to those teams. So what I'm going to do is I'm going to go through a few bits, and then if it's okay with you, Chair, I will just go straight to the questions, because it's probably better for you to ask me what you want to know rather than me try and tell you what I think you want to know. So a couple of things. So we stepped up additional critical care capacity through this pandemic. We stepped that capacity up, and at no point did we run out of critical care beds in Cambridgeshire and Peterborough. We managed to do a discharge programme, a joined up discharge programme across health and care to get effectively acute facilities a little bit emptier, to be able to redeploy the staff, to be able to create enough of that critical care capacity and keep people safe from an infection prevention and control within hospitals. But also we saw our 111 service provided by Hearts Urgent Care deal with unprecedented amounts of demand, patients' queries, and keeping going. We saw primary care completely change their delivery model into using virtual. So we issued out, I think it was just under £1 million of capital on IT to make sure that all of primary care had access to kit and cameras and everything they needed to get as much virtual in the very early days of this pandemic. And through this, although referrals for cancer services did drop, actually the services treating and the appointments to see those 2-week wait patients did not stop. So there was a maintenance of critical services as well. We moved staff around, and we have had to temporarily close and change some services just because of staffing, because we needed to make sure we had enough staff in the right place. And I would very quickly, and Liz will probably want to comment on this, talk about the care homes in that the work that CPFT and the CCG staff turned to help and support the local authorities to make sure that we could get as much staff facing those care homes as possible when there was definitely a difficult patch for them in the early days. But I think the teams worked together on that. So that redeployment of staff was only able to happen because we were able to effectively move around services for this temporary position. The bit that we're faced with now is it's actually far easier doing that initial switch around than it is doing 2 things at once, which is being ready in case we do get a second surge and making sure that we are well prepared for that second surge. And as Liz said, promoting all of the rules around social distancing that we need to maintain, but also trying to stand back up as many services as we can within quite difficult infection prevention and control guidance. And actually that, I think, is having quite a big impact on how quickly we can step stuff back up, because we're trying to do it as safely as possible. So we continue to use independent sector provision to get as much capacity in the market as we can, and we continue to work with our whole range of providers to making sure that not only are they able to give us as much capacity as we can, they're doing it in that correct infection prevention and control mindset. And we're also very, very conscious about people's commercial viability, particularly key services like hospices, which I'm actually very concerned about how they're going to maintain with the reducing charitable incomes. So there is a whole range of stuff that we are trying to do. As I say, there was a dip in capacity, and until we are through that infection prevention and control, that capacity will be coming online quite slowly. And therefore we are in health talking about our recovery plan now. The phase that we're in now is going through to the 31st of March 2021, with our main objective being how do we keep people as safe as possible. As Liz said, though, that we are acutely aware about how COVID has magnified and put a big light on health inequalities. And I think that's something that we really need to hold a mirror up to ourselves on and look at how we are really dealing with those health inequalities going forward. So all of our recovery plan is not only built around the infection prevention control, building capacity, it is also built around how do we do as much to do with those health inequalities as possible, because I think it just really brought that to the fore, and that does concern us. We are working closely with Liz's team, and I think if there's one out of terrible times, which, as I say, we wouldn't really want to ever have to replicate, there has been some good, and I think we do need to remember that. And that I would like to say that I don't think the way that local authorities and health have worked together has ever been as good as it is now. Actually, we are joining up as one and really trying to do as much as possible. And I take that as a real positive for people who now have quite complicated pathways with multiple people going in. The more we can work together and simplify things for people who need care, the better. So I think that's a real positive. I also think the closeness that health is getting to places like the districts is really important, and actually really getting that local feel. Again, we are getting a level of engagement and working together in a way that we haven't before. And again, I think we're all very much valuing that. I think the other thing that's really happened is through all of this, the adoption of technology has just opened up a world of opportunity and a set of expectations for people and staff that we never had before. So if I think about, we were trying to transform outpatient services over 2 to 3 years, and we've done quite a lot of that within 2 to 3 months. So what we're really concentrating on now is saying, where does that work, and where does it add value compared to where do we need to go back a few steps? Because just because you've changed something and it's been really innovative and it appears to have worked doesn't mean we should take it for granted that that's what we want to keep. So we're really trying to get that balance between the good stuff that we've got and making sure it's really what we need going forward. So overall, I think it has been unprecedented. I think that we have done, I'm quite proud of the way Cambridgeshire and Peterborough has reacted, and Liz has gone through the performance, and I think that's down to how the public have been communicated with. I think it's how all the services have lent in, and how, if I put this quite bluntly, having excellent world-leading hospitals like Addenbrooke's and Papworth in our patch, that not only are there to support local residents, but have really supported the excellent work that North West Anglia Foundation Trust did as well up in Peterborough and Huntingdon, has just been absolutely phenomenal, and we should feel very lucky that we have those great institutions in and around us to support all of our population. I should stop there.
Yeah, thank you. Well, we'll now move to the questions. So I'll ask a question, and if you could respond sort of to the point and concise, please, that would be very much appreciated. So the first question is, from the perspective of the CCG, how effectively have health and social care worked together during the pandemic? What have been the key challenges, and what have the CCG learned from them? Thank you.
So I've kind of answered a little bit of that already.
You have, yeah.
I think the example around care homes, I think the example that Liz gave earlier, that it's the CCG data team and the public health team that have done all of the surveillance work, and now we've got integrated data teams across the two, has been really powerful. I think, if I'm going to be quite candid about this, money being off the table has really helped everybody in terms of being able to work together, because obviously we have got a very cash-strapped system. And actually, when we're looking at being able to set up services and know that we can do that based on the freedoms to operate together, I think that's very helpful. So I think there are some real tangibles. I'd say care homes, I would say the work they've done on with the Health Protection Board, I think the work that we've done on data has been outstanding, and the way that Gillian and I have co-led the SCG, I think, has naturally made sure that we bring everything together. I would say it is always easier though when there is some freedom and some momentum behind us all having one single aim. So we all knew exactly what we had to do, and we were all doing this in the interest of those patients' safety. That does give us a very different dynamic than what we've had before.
Thank you, Jan. Have any members any follow-up questions specifically related to the response from Jan? Please raise your function hand now. If not, I'll go on to the next question. Oh, quickly, just in time, Councillor Jones.
Sorry, I'm not trying to hold us up. It's just that Jan had said that she thought they had learned a lot, and she thought care homes was a good example of success. And that isn't necessarily how many residents would see it. So I wanted to understand what she meant by that. Could you explain it, please?
Yeah, thank you.
Yeah, so I think care homes is so interesting, because accountability for a care home sits with the local authority. They do the vast majority of the commissioning through that. But I think the skills that the CCG has around safety, quality, infection prevention and control have through this time really complemented it. And I think it has been very tricky for nursing and residential homes. I think you're absolutely right, Linda. I wasn't saying that it hasn't been very tricky, but actually the way our two teams have said, here's the knowledge and the contracts that we have, here is the expertise that we can layer onto that with nursing, in that we ran out education programs on infection prevention controls across the homes. We provided advice and guidance to those homes through the nursing, particularly under the excellent leadership of Carol Anderson, our lead nurse, through that time. And for the first time, we were sharing intelligence, I think, on those homes to make sure that we could now, fairly early on compared to other areas actually, really get ahead of making sure that we could support the homes that were as vulnerable as early as possible. I think again, if I'm quite candid, the anxieties around the challenges between homes being effectively private with a level of autonomy and governance with the CQC compared to actually then the level of support needed, and actually getting them to understand what would be in the best interest was quite a challenge. Liz, I don't know whether you want to comment on that at all, but it was quite tricky. So the way that the teams formed one team really quickly, Tracy Dowling and CPFT just freed up a load of staff as well, so that we could actually go and be present in homes in a way that before we just didn't have that level of resource all focused on homes. So I'm not saying it's not a really challenging problem in homes, but actually I think regionally we were definitely ahead of the game, and the support that we gave wasn't easy, but I think we've definitely had a big impact. And for those that are interested, we did a specific paper on this to our CCG governing body that happened on Tuesday. So I would urge people to go and have a look at that care homes paper for more information on that.
Thank you, Jan. Thank
Is
you,
there
Linda.
anything to add to that on the care homes? Just so I don't miss it.
I would echo what Jan says about the support from the CCG infection control nurses, and the way that they have absolutely worked very, very closely with our adult social care teams to support homes, and to, in a sense, take the advice from Public Health England health protection team that's going into the homes, and then implement that, and the whole system has joined up in a very positive way, with no one thinking about what organisation they worked for, or where the money was coming from, or boundaries, just about doing the best thing for the care homes, because it was very challenging. And there, you know, as we all know, it's a very difficult area, but it was a complete commitment to sort it out, where people forgot about organisational boundaries. And I would support Jan on that. Excellent input from Carol Anderson's team and the CCG infection control nurses.
Thank you, Liz. Thank you, Liz. Jan, I'm going to go on to question 2 now, please. And the question 2 is, what has been the impact on your bottom line? Have past debts formally been cancelled? Has the CCG got, or assured of getting, the funding for the extra 400 beds and other costs such as PPE?
So, so throughout COVID, NHS England and the regulators, we have worked very closely with them. So people, just to make sure people are aware, we are accountable to our NHS regulators, which is a blend of NHS England and NHS Improvement. Any spend that was COVID, for example, like the nearly 400 additional beds we purchased right up front to make sure we had enough capacity, which has also provided some good commercial support actually to homes through this. We had to go and we almost sought pre-approval for those items before, so that we would guarantee to get the money back for those, so that we knew that we had any large COVID costs covered before we spent it. And again, how we worked with the regulators through this time was quite unprecedented actually, in terms of getting that pre-approval. They have changed our financial regime and are aiming to get us to break even by the end of month 4. We are a little way off break even, but by hundreds of thousands, not millions. So I think that is a positive thing for the CCG. But they have also changed the financial arrangements for foundation trusts and large NHS organisations as well. So actually we're not seeing the traditional pressures. We don't know how long that's going to last. We've only got the arrangement in place till the end of month 4, and we are unclear as to the financial arrangements from there on in. But as I say, our regulators are being very supportive. They understand how tricky this is, and they understand the level of work that everybody is trying to do. So I don't have any guarantees on money, but I can tell you that so far our regulators have been very supportive of what we're trying to do, and we have also been very respectful of what we've asked for, because we've asked for what's vital and important in what we need.
Thank you, Jan. Has any member got any supplementary question on that subject? Raise a hand, please. Okay, great. Thank you, Jan. Thank you for that. We'll go on to question 3. How timely and adequate has the information flow been, whether via the Department of Health, the Care Quality Commission, or Public Health England? What adjustments or improvements in that flow could assist the CCG in the future?
So I think very early on, we realised that if we just went off in health and got a load of data, Liz's team went off and got a load of data, hospitals kept the load of data, that wouldn't help us. So we created the intelligence cell early on to try and put together as much information as possible. And I think that has been a revolution for us in our system, because our data teams have all been working together. So so early on, we all agreed on a predictive model that we would look and track on to see if we were going where we thought we should go, and we've managed to track as much data as we have together on an ongoing basis. So I think that integrated intelligence hub has been fantastic and something we should definitely retain. However, we always would like more, wouldn't we? And I think you've all touched on it earlier on when Liz was talking. I think it has been difficult. So it has been difficult with the local data, and particularly on the swabbing results. And of course, early on, there was an issue with results going back to the person who'd had the test and not necessarily coming through things like the employers or through us in health or through Liz in public health. And things like that proved very tricky, especially when, so if we go back to the example of nursing homes, we had some nursing homes with high staff sickness because they're reporting positive swabs that seemed very high compared to other places, and we had no way of knowing, we had no way of comparing because those results were going back to people. So there was some stuff that was quite tricky early on. I think the other thing that I have spoken about this morning actually with my regional directors team is actually that comparison across the regions and across the areas across the east of England. We would like to have seen more of. So looking at how some of the effects now that's going on in Leicester compared to what's happening in Bedford, what's happening in Luton and what's happening in Peterborough, that is really valuable to understand those trigger points. So as well as more local data early on about the testing and the results, I think the second thing would be just opening up some more comparisons so that we can really get a feel for what is happening elsewhere so that we can learn from them, and also be very clear on some of the factors that we think might have contributed to their problems so that we can help avoid some of those. So that wider view, I think, would have been more helpful. I think also, I think our regulators were very good at switching off a lot of the regular asks to allow us to be focused. I think where we are now is that we're getting lots and lots and lots and lots of requests. And actually that is now becoming to the point where that is becoming quite a little bit distracting again, because people say they want more information, and there is a point that says actually that we need to make sure that we can get what we need to get done as well as providing information back. So I think I think we're just on the cusp of making sure that we're not actually creating more information than anyone could actually use, because let's face it, if we get it, we've got to use it.
Yeah, absolutely. Thanks, Jan. Has a member got any supplementary question on that comment from Jan, please?
Whoops. Yeah. Yes, please.
Linda Harford.
And Susan, I think.
Linda.
You're on mute, Linda.
God, sorry. I just wanted to go back over the results because as Liz Robin knows, I was a nuisance about testing for a prolonged period, and I did speak with Carol Anderson, who was fantastic, and she was definitely concerned at that time about the time that tests were taking to come back. We're being told nationally now that they're being turned around in 24 hours, with the exception of home testing kits, which they say are about 48 hours. And I have to say, I've experienced that home testing, and it was 48 hours. It was brilliant. But I would like to hear from you what your experience is of the promptness of test results now, because as far as track and trace is concerned, that is going to be crucial. Thank you.
Yeah, so as I say, if I'm completely honest, Carol and Liz know way more on this than I do. So again, Liz might want to jump in, but from what was escalated to me and through SCG was that that early on delay, and I say early on, it went on for quite a while. Delay on the test results was a significant problem, especially when we had people whose test results were taking longer on a few incidences than the incubation period was. So, but that has now rapidly improved. That really was a problem up front. And also, as I said, the feedback on those test results was a problem up front that really worried us from a risk assessment point of view. But I think a lot of that is now has resolved, and the testing is much smoother, and the results are coming back more consistently. And that is, again, I think that will continue to improve as we go forward. I think I have an ongoing anxiety, which Liz, I'm sure will again be much more technical than I am, which is with the different types of testing with the pillar 1 and the pillar 2. The pillar 2 results seem to be coming back with far more positives, and I think we just need to be mindful of that. And so I think there is an anxiety now that once we've got more of the testing going, the results are coming in, we do just need to keep coming back to what is it really telling us, because as the pillar 2 results go up, for example, we're not seeing the admissions to hospitals and we're not seeing the changes in there. So we've really got to be careful, I think, now, in that just because we're getting the data, we've really got to be clear on what it means. Liz, I don't know whether you need to say any more on the pillar 1, pillar 2 thing.
Liz, perhaps you could mention that later if we have time, but not now. Yeah.
Okay.
Susan, please.
Thanks. I'll wait and ask Liz a question about testing afterwards.
Thank you. Thank you. If we have questions that are more likely to get a better answer than Liz, then we need to wait for Liz for later. Nikki, please.
I'm going to wait for later.
That's nice. Thank you. Lorna?
Yes, I just wanted to go on to, am I too early to come on to the Sir Simon Stevens letter?
To the Simon Stevens letter? No, go for it.
Because I think I'm a bit confused by where we're going with this as a committee, in that we're being told that if we have a meeting next month, we'll consider it next month. But if we don't have a meeting next month, we'll consider it today. And we don't yet know at this stage whether we're going to have a meeting next month or not. So I'm in a bit of a quandary. There's a lot of material in that Simon Stevens letter. We haven't had anything in writing. I wondered whether you were able to give us just a response, general response about how locally the health economy has been able to respond to the asks in the Sir Simon Stevens letter, and the extent to which there have been difficulties in moving forward with those. And to ask whether, if we're not having a meeting next month, we could actually have a written response of a couple of sentences to each of the various things on the list.
Thank you, Lorna. As far as I'm aware, I have a date in my diary for a meeting next month. There are no service committee meetings in August except the health committee.
If you're telling us, Chair, that there is a meeting next month, that is fantastic, and I will reserve my question until then, and hopefully we will have something in writing to go with. But my understanding was we weren't yet completely certain that there was going to be a meeting next month.
Rob, could you confirm, please?
At the moment, yes. I think there will be a meeting now. It's the only service committee that has been asked to meet.
Yes, quite right too. And we can have that as an agenda item. Yes, Liz, would you agree?
Thank you, Chair. But in case Jan is not going to be able to be with us next month as well, and I'm convinced she has other things.
Yes, Lord. Yeah, perhaps.
I will be.
Jan, wait, I'm in charge. Perhaps Jan could send a written response in case she's not available in August.
And in the meantime, Chair, if there's anything general she would be able to say
Absolutely.
at this moment, a sentence or two.
Yeah, quick brief, please, Jan. Thank you.
Yeah, so we've had lots of instruction. We're under a a level 4 national emergency. So in addition to, we've been having regular asks, not only in that Simon Stevens letter, but there is a series of instructions that has been coming down. And if I'm honest, the bit that has been quite challenging is that, and I think again Liz will agree with this, is things change quite regularly. So a letter is written, we go and deliver, and then we learn something new and something else has changed. So I always said the letter was as good as probably the day we landed. It landed, and then we had to do the best we can. What I will do is I will make sure we get a written paper back on the specifics in the Simon Stevens letter. As I say, where we are now, though, is that I am really anxious about making sure we've got enough capacity to sustain healthcare services. We know that, if I'm honest, waiting lists are going to be a huge problem because we just don't have the level of productivity through because of the infection prevention and control. And we also have a problem because lots of staff are redeployed into different things. So if I give you an example, many of the diabetic nurses, and diabetes is a big influence in the outcomes for COVID, are now actually working in the discharge to assess pathway to make sure that we get people into out of hospitals as quickly as possible. So there is big challenges with A, moving staff back around, and B, just that pure capacity because of that infection prevention and control. And what we are very worried about is actually public expectation on what is possible to do going forward, because we know A&E activity is now creeping back up, primary care activity is where it was before, and 111 activity is creeping up to now being higher than it was before, but not back up at COVID levels. So that is the real quandary that we have got.
Thank you very much indeed, Jan.
Thank you, Jan. Thank you, Lorna, for your really important question. And we can discuss this in more detail, hopefully, at our meeting in August. If we get a written response, Jan, perhaps if you'll be so kind for us to discuss, that would be great. Thank you.
Can I just, sorry, Councillor, can I just say one thing? On our governing body papers, and again, we can, I don't know if it's appropriate to get these circulated, but there is actually a performance report on there that has a specific COVID report as well. So there's a report on care homes and there's a report on with all of the data on. So there is public data out there that we have published. So we should make sure that you've got copies of those as well.
That would be very good. Thank you very much indeed. Thank you. I was going to ask a question 4, but you've answered a lot of the question 4, and I'll leave that in case we have time. I want to go now to Councillor Connor, please. Councillor Connor, and could you ask Jan that question we agreed on?
Yeah, thank you, Chair. Hi, Jan.
Hello.
Something very dear to my heart, the minor injuries unit at Doddington. As local member, it would be rather remiss of me to miss this valuable opportunity to ask you when the minor injury units at Doddington is likely to reopen, especially as we've just heard in the report just given to us from for the Health Committee here today from our Public Health Director Liz Roban to say the cases are going down as best we can. As we have discussed at length before, it's absolutely essential that Doddington MI unit and MMR unit reopens as soon as possible, as it is really important and a much needed facility for Fenland and residents and further afar. So I suppose the question is, of course, after that, when's it going to open or reopen?
So the straight answer is I don't know. I have said publicly multiple times it is a temporary closure. It is not a closure of Doddington. The reason I don't know is because of that staffing issue, in that those staff are still redeployed. I think we've got to be very careful to assume that because the cases are down and the cases are down in the hospitals, that everything can just flip back. It isn't like that. As I've said, we've got multiple staff working on the discharge to assess pathway. We've got multiple staff redeployed. If there is an outbreak, then some of those community staff will also have to be redeployed to do things like testing and swabbing. So we are working with the local providers. It is temporary. It will reopen. We don't have a timescale yet for when, because we are trying to move all of the staff back round. We are completing our recovery plans for our regulator. There is another draft of that going in a couple of weeks' time. And again, I'm very happy to bring our recovery plans back so they can be scrutinised by this committee. But it will form a part of a bit of a chain of events, because we need to free up the staff to be there. And
yeah, thank you for that.
Closed it because of staff, and we can't reopen it until they're back and available.
Yeah, thank you for that. Thank you, Chair.
Thank you, David. Thanks, Jan. You know, the minor injury units are very close to this committee's heart, all of them. But we also understand the staff have been redeployed on the COVID issue, and we can't expect them to go back until they're available to do so safely. So we will keep that in mind, and we will be looking at this in the future for updates, please. Yeah. I'll just ask one more question because we've got a couple of minutes. What has the cumulative effect of focus on COVID on patients with other health conditions and treatments delayed? What is the expected casualty, and what plans are dealing with the tailback, bearing in mind the potential eventuality of a second wave? You've answered some of this already, by the way.
Yeah, and I think if you ask any healthcare leader at the moment, this is the thing that definitely started keeping them awake very early on, which is how do we reduce harm as much as possible to the wider population. I said earlier on about the cancer services. but we know that we've had a significant reduction in capacity of diagnostics. We know that the referrals went down. We know that people who have uncomfortable conditions, maybe not life-threatening conditions, are having to put up with pain and difficulty for a longer amount of time. So reduction of harm is definitely the focus of our recovery plan. And I would say, I think we're all anxious to make sure that we have all the processes in place that we can mitigate risk as much as possible. So let me give you a few examples. So we are working with the clinicians to make sure that we are reviewing referrals to come in so that we make sure that we are treating them in the appropriate ways. We are working again with all of our clinicians who are scanning waiting lists to make sure that again we are treating people appropriately, and we are picking up any risks that we have there. We are looking constantly. I think primary care feels quite vulnerable at the moment because they had very few places to send and refer patients to. So there has been a strong advice and guidance put in place, and we are now working. It is more tricky. There's a slight technical issue for Addenbrooke's that we are still working through on the referral pathways, but we've switched on much more advice and guidance for clinicians. I think the key to all of this, though, Councillor Hudson, is that I think we need to make sure that we get as much diagnostic capacity in and going as possible, because that diagnostics will be very important. We had through our regulator been asked for additional capital requests so that we could make sure that we could reduce that harm and get some additional capacity in. Diagnostics hubs was a big feature on that. It is unclear to me whether that capital is coming through. In fact, I think it's unlikely that it will. So we're going to have to now find other alternatives for things like getting that additional capacity in. But I think every chief exec in the health system would say that the majority of their time was taken up with not just COVID, but also looking at the harm and actually trying to work out what problems were building up for the patients who were non-COVID.
Thank you. Does anybody have any supplementary questions on that for Jan? Linda with a Y, Susan and Lorna, you've still got your hands raised. If you could take them down, please. Thank you. Any other supplementary questions for Jan? My Alexa is just about to make a noise at me.
Well,
Susan, yeah, Lord, oh, Susan, yeah.
Simply that, I mean, I having lodged that question, I realized immediately it's far too broad.
Yeah.
And this is what we're going to be talking about in the months to come, I'm sure. So just to acknowledge that.
Yeah, yeah, there will be recovery programs from the CCG, from the County Council and everywhere else, I've no doubt, for us to discuss in the future. Thank you. Linda Jones.
I just wanted to sneak in an earlier question about, or an earlier comment by Jan about information sharing and how you did that fairly early on and brought the streams together and did the predictive work. Really interesting. What I was burning in my mind was how much of that are you going to manage to keep going in the future? Because essentially you're still dealing with a system that is dislocated and where some parts of it compete against others. So to me, the big learning, as you say, is about how you link that with the STP to make some of the STP more than just a wish list and work. And one of the key elements has got to be the information sharing.
So yeah, absolutely. So through COVID, the CCG has taken on more of a system leadership role, as I explained, with me running Health Gold and co-chairing SCG. I think that what we have learned through that is some of the structures that we put in place have been very valuable. The discussions I'm having now with our regional director and Roland Sinker and Mike Moore are about how, when we move forward, because we have to move forward into an integrated care system from health, and how we lock in the lessons that we've already got through this and how we don't lose it. And I think Mike Moore and I are pretty consistent that we keep talking about the intelligence hub, really talking about how the clinicians have helped driven the agenda. So, you know, how the public health team, how the public health experts in the CCG have really driven our agendas. And we actually set up a clinical cell, which everything ran through as well. That proved absolutely invaluable for us. So there is ongoing discussions as to how we retain it. I think the other thing that we do need to keep improving and working through is how that we get more information and wider agendas at the Health and Wellbeing Board as well. because you know, prevention and what we're doing through the routes. So for example, we've kicked off a massive program on obesity purely around COVID, because the links from obesity to diabetes are huge. The complications with COVID with diabetes are huge, and the survival rates are really affected. So actually, you know, whereas previously we would have said obesity is not our business, that's down for public health to sort out, we've just said we can't. We're just bowling in on this to really lean in and wrap around public health on this, because if we don't, we're going to have poorer outcomes for our population, and that's not good enough.
Thank you, Jan. Thank you, Jan. Linda, are you okay with that? That's quite a good answer, I thought.
Well, I'm cheered by the response. I mean, I wish that, you know, there's something more at national level that was supporting that, as opposed to the regions and localities having to do it themselves. But that's another comment. Yeah, thank you. And the last question, please, Kevin.
Thank you, Chairman. Just a quick one for Jan. Regarding the referral pathway, and like all the others, we're really pleased to see it's getting the attention it deserves. But there are serious issues within the system where referrals have already been made, particularly in oncology, where diagnostics like scans and that for stemming secondaries are not taking place at all. And therefore, it looks like we're building up some problems, not only from people's serious health issues, but all financially as well.
Yes.
Alexa, stop.
Yeah, and I'm really worried. As I said before, we've put in some requests for additional capital that have gone up nationally to make sure that we can get some additional diagnostics capacity. If we think about, if I look back at May, there was a reduction of 70% against the rolling average in May for diagnostics that were completed because of COVID. And there was, and that was 37% up from the month before. So we do have a problem. The percentage of patients we're seeing within the 6 weeks, which is our target, has reduced, and we need to get as much capacity in as possible. The issue is, though, we do need to do all of that within infection prevention and control guidance, and we have to do that safely, and we have to do that with staff that are acting in a safe way. And that's where if we can get the capital for the diagnostic centres to really be able to get much more wider access to community diagnostics for GPs and community services, I think that will help us unlock quite a lot.
Thank you, Jan. Thank you very much indeed. Your time's up, and we're sorry to see you go, but please take with you our absolute thanks from all the committee and everybody to you for all your fantastic work. Please pass on our thanks and admiration to all our healthcare professionals out there, and we look forward to seeing you again. Thank you.
I'll pass it on. Thank you very much for your time.
Thank you, Jan.
Bye.
Take care. Be safe. Okay, members, thank you. Before I go on to the next agenda item, which is, I think, is the agenda plan, shall we go back to Liz? And for any other questions you may have for Liz, Linda, Councillor Linda Jones, you have your hand up still. Are you premature or just waiting? Yeah. Okay, Liz, you're there. Okay, Linda, you're on. Nikki.
Hi, it's just a quick question in regards to the testing that Jan mentioned, and saying that we're getting more positives from the pillar 2 than we are from the pillar 1 testing, and that is raising concerns. Now, is that just because we are aware that therefore there is a level of COVID out there that is higher than we think? Because it's very unlikely, we can't get a false positive, right? We can get a false negative, but not a false positive result. And what do we think that might mean in regards to the going forward, the danger of COVID? Are we thinking that maybe COVID is becoming less dangerous, or is that data not there yet?
I think pillar 2, I think when I look at the levels of COVID-19 in a community, I don't just look at the tests, I look at the Office of National Statistics survey, which takes several thousand people and tests them again and again on a regular basis. And what that shows is that there's a certain level of COVID-19 in the community, and that quite a lot of the people who have it do not have symptoms. And some people do have symptoms. So you're never going to pick up the total numbers of people out there in your community with COVID through just testing when you've got symptoms, which is what the programme does. So we know, and I think the ONS survey is probably the best tracking of it in a sense at a national level. We know that we have got some people with COVID out in the community, that there is some level of community transmission, and that's what all the national alert levels say. And in a sense, that's a bit more reliable than just looking at the test results. So what the Pillar 2 testing is doing in our experience at the moment is it's picking up two things. We're really encouraging people to get tested if they have symptoms. So it's picking up people with a positive test who then self-isolate their contacts, if they show any symptoms, get tested. That's good. We want people to get tested. And we want them to self-isolate. So we want, lots of people to do that. And that will pick up more cases than we were picking up before Test and Trace came in, inevitably, because we're saying to everyone, go and get tested. If you've got symptoms, go and get tested. The other thing is that there's quite a lot of Pillar 2 testing of care homes. And we now know that there is quite a lot of asymptomatic COVID-19 in care homes. So the Pillar 2 programme has been testing whole care homes, residents and staff, which aren't having an outbreak at the moment, but just doing that screening. And Pillar 2's also picked that up. So if you get a blip on Pillar 2, it's often a care home asymptomatic testing coming through. And we don't always know about that because it's done directly between the national testing centres and the care homes. So sometimes we have to follow up and find out after the blip is seen. So I think it's a bit of an unknown quantity, which is why it hasn't been added to the national published results at local authority level until now. It shows what we know, which is that there's a certain level of COVID-19 in the community, a certain level of transmission, and that's why everyone needs to maintain the infection control measures and social distancing. So in a sense, I'm not concerned about that because it's showing some cases, because it's better to know about them. I would say that in Peterborough, Peterborough's really jumped in terms of its position in the league tables. Cambridgeshire hasn't so much, or anywhere near as much, but Peterborough in particular, we think partly because it's got the big drive-through, but also because of some of its social characteristics. We talked about areas of deprivation earlier. That's showing quite a high rate of Pillar 2 tests compared to Pillar 1, and that has been quite a big change for Peterborough, the change in its national position when you bring in Pillar 2. So Jan may have been referring more to that, I think, in terms of her overall thinking. That's where although Huntingdonshire has gone up a bit on the Pillar 2s as well, it's not anywhere like the same. So I think we're keeping the Pillar 2s are going down in Peterborough. I'm very clear it's not a Leicester because it's actually trending downwards, not upwards, and Leicester's was trending upwards, but we really particularly need to keep a close eye there. And there may be points at which Cambridge becomes of more concern because of other factors. If you get a big influx of people coming in because university returns, whatever, I don't know quite what the plans are at the moment, but different areas will be of concern at different times. But at the moment, I would say that the concern is more around Pillar 2 in Peterborough and the areas of deprivation there. And we're keeping, although it's going down, and it's generally going down around this area, we are keeping a very close eye on it.
Thank you. Lorna, your hands up.
Yeah. Thank you. I just wanted to go back to the use of the word cases repeatedly in the documentation we're given, and I remain very concerned, and we've mentioned this a number of times today, but I think it bears reiterating how very much this is partial data. There is a lot of stuff we don't know. There is what we're calling data, but in many respects is not anything like a full picture. And I remain concerned that without that data, and without that data shared down to local councils and local communities, the behaviour of our local communities when it matters isn't going to be affected when it needs to be affected by reliable data. And I know that that's being worked on. I believe, and I'd be grateful for an update on this, I believe that the district councils are in the process of signing data agreements to get that more granular data, and I'd like to know how that's going. But there just isn't enough reliable data, and that's not a local problem. It's not something particular to us. It's not anything to do with this authority or anything that we've been doing. It is a national problem, by and large. And I just wanted to bang the drum yet again for the COVID-19 app, which millions of people, I think it's around 3.5 million people in this country, are recording their data, whether they're feeling fine or feeling ropey, every day, and have been doing so for months. And I think that there is a massive resource of information there that is only beginning to be tapped. And I know that some arms of government are beginning to talk to King's College London about the app and what it can bring to the table. And I know to some extent it's self-selecting, of course it is, but it's, in my view, no more inaccurate than much of what we're being given as being data. And it does present a rather different picture in some respects. And we've been talking about Huntingdon a lot. The COVID app, and I will come back to this, keeps coming back to Fenland within Cambridgeshire as being somewhere that we need to be keeping an eye on. And I trust that information. And I also think that the information we're seeing there about the levels of cases is as reliable as anything else we've got, and maybe a bit more. And I do want to encourage as many people as possible in Cambridgeshire and Peterborough to sign up to that app and report, because the more people that do, the more valuable and the more accurate the information is that will provide. It's already begun to guide public health. It was the thing that in particular picked up the loss of sense of taste and smell that is now recognised as an indicator. That came out of that the work of that app. And I would strongly encourage, if anybody isn't using it day by day, then I would strongly encourage them to do so. Thank you.
Thank you, Lauder. Is that a question or a statement?
Yes. There was a question in there about the extent to which the data sharing was going, the agreements were going. I
quite lost the question. Liz.
Oh, well.
Okay, so yes, we are working on data sharing agreements with the district councils. So we want to, and we are in communication with them, and we want to work with them. So yes, and as I said very briefly earlier, we are looking at the postcode data at the moment, only getting it weekly, but hoping to get it more frequently as part of a pilot. And and then we will keep a very careful eye on that. And if there is a need for additional communications or work with the community, we have the people on very linked into our central team who can action that when appropriate. So I agree with you, Lorna, none of the data is perfect. Not everybody gets tested. Not everybody has symptoms and knows that they need to get tested. So we're still, we're still kind of 6 months into this disease. So, and we haven't got everything that we would like to have in terms of knowledge, but we're getting more and more knowledge, and certainly we're very aware of the need to look at that data and to take action in communities where appropriate.
Thanks, Liz. Susan, your hand's still up. Is that a new hand or an old hand?
It's my left hand now.
Oh, is it? Go on then.
I'm going to be Susan is an old hand.
Also about testing, if I may. I suppose as a local member, I wanted to raise the concern about significant delays in receiving test kits for people who have booked on the internet or self-reported. And I guess the question would be, to what extent would that kind of information be available to you? Maybe that's inherently difficult, because bound up with some of these delays are communication problems. So a test not arriving when it was meant to, and then 2 tests arriving a few days later, that kind of thing. That's a concern. And I just wonder where that fits in the picture in terms of the local authority work, and how this is. What should people do when this happens? It does undermine confidence.
That's a good question, Susan, and we're actually looking at how we can get sources of soft intelligence from a local level back into our central outbreak management team. And looking at how we can maybe do that sort of through district level communications, where these things tend to be picked up more. Or through other routes. So it's anecdotal, but it is also not that I have heard it elsewhere. I'm sure that the majority of time it works okay, but you do get cases where it doesn't. So I think it's always very useful to have that feedback of where things aren't working perfectly. And there is a national phone number around booking a test. I can't give the exactly where if there's another helpline number or something like that, but certainly there is a phone number for booking a test. So I would sort of maybe say maybe people should be calling that if they have a problem. And it's a national testing centre. I think there is something about if we are in a difficult situation with a local outbreak in a setting, having our own testing capacity that we can be absolutely sure of, so that we can send that in, get the tests and know that we'll get them turned around at a local lab in 24 hours, rather than relying on people to get an internet test and perhaps there is a delay there if there's a postal problem or something like that. So that is something that I can assure you is in our thinking. And maybe help address a bit of that concern. But no, it's always useful to get those sorts of feedbacks, and we are looking at how we can do that in a more in a very organised way.
Sorry, Kevin.
Okay, thank you, Chairman. I wonder if the Director would wish to comment on what I'm about to say, and I won't be offended if she feels it's not appropriate to comment. But back in January and February, I had a very long conversation with a Chinese doctor, actually come from Hong Kong. And like most Chinese doctors, extremely clever and intelligent. And he said it would be very bad, this is COVID, but die down in the summer as the virus does not like warm and high ambient temperatures or ultraviolet lights, but will increase again in the autumn as the temperature drops and violet light decreases. Now, I think this is borne out by the high instances in this summer period by outbreaks in colder environments like food processing plants. Now, is it a coincidence, or do you think there's any sort of truth? And remember, he made these observations back in January and February, where very few people had heard of COVID. I certainly haven't. Thank you.
I think that's a very interesting and good question. And as a local jobbing director of public health, I would refer it to colleagues who spend their full days researching this and have a really good understanding, because I'm not the right, it's a very good question. I'm probably not the right person to answer it. Because for a question like that, you need to be absolutely in tune with the latest academic research and thinking. And you know, I do my bit, but I'm spending a lot of time operationalizing things rather than spending my whole day on the research. So.
Thank you, Liz. And thank you, Kevin. Last question on this then is Anne, please.
Thank you, Chairman. Just for the benefit of members of the public who may be watching this, I just wanted it clarified that Councillor Dupre mentioned the COVID-19 app. This is not the Test and Trace app that was trialled on the Isle of Wight by the government, which proved ineffectual, because I think some people listening to this might confuse the two.
Yeah, Okay, yes, thanks for mentioning that. That's quite important. Thank you. Okay, we're going to move on now. Thank you, Liz, for coming back with those questions. So we go to the agenda plan. Rob, can I ask you to introduce the agenda plan, please? Rob, you're on mute.
Sorry, agenda plan is as set out there, because obviously the meeting of June the 25th was so close together to this one. There's a number of items listed at the end of the plan regarding, they're listed in the bullet points there, which were raised at the last meeting, and officers would be looking to add them to future meetings, and also some of them would come back probably in the usual monitoring reports coming back, some of them perhaps in the COVID report. So, and obviously we've now had the update that the CCG will be bringing back a paper on Simon Stevens, the response to Simon Stevens to the August meeting. So not really much else to add.
Thank you. Lucy, you've put your hand up.
Thank you. I think it was incredibly important to have Jan to this meeting and really, really helpful. I wondered whether it would be possible to ask, is it Tracy Dowling from CPFT, whether she could come to our meeting in September, because I think the work that they've been doing is also very important, and I think it would be very useful for us to be able to understand both the impact that the COVID-19 pandemic has had on their normal work, and also how they've been supporting the work for the pandemic. So I wondered if we could add that to the September agenda. Yeah,
thank you, Lucy. And we'll also put that on the agenda for the next chair and lead members meeting, and we'll discuss it there to find a spot for it. Yeah, thank you. I'd just like to mention that the COVID-19 review of council performance and lessons learned, that's on the list of possible agenda items in the future. This was discussed at a recent chair and lead members briefing, and it is not really a health committee function to scrutinise the council as such. However, this is a council-wide review, and a review is started to take place as we speak. I've spoke to Amanda Ascombe, who's doing this review, the County Council's recovery programme, and there will be a section in that about exactly what we've just said, a review of the council's performance and the lessons learned, and that will come to the General Purpose Committee. So members on this committee, or also on the General Purpose Committee, can see that, and it'll go through chair and lead members and also group leaders. So that hasn't been forgotten, and it won't be forgotten. And I'll keep my eye on it, on how that goes forward. I have already discussed this with lead members of this committee. Are there any other thing anybody wants to say quickly before we, Linda?
Yes, thank you for that, Peter. That's a really helpful statement. Can I just check that if I can understand that it's a whole council issue, and absolutely right that it should be. If there are particular issues for the health committee, and in either our scrutiny or our public health function, can committee be assured that those will be able to be discussed in the committee?
Yes. If there's anything particularly appertaining to the work of this committee, and that it will be discussed with the Director of Public Health and our officers, and it will come to our committee. Of course it will, Linda. Absolutely. Okay. Anything else by anybody at all before we call it a day? In that case, I'd like to thank you all for attending today, and thank you very much indeed. It's lovely to see you all. I can't wait to see you in real time, and stay safe. See you soon. Thank you.
Thank you, Chair. Thank you, everybody.
Thank you.